Good afternoon, everyone, and welcome to today's webinar, Migration, Displacement, and Cancer Care Access in Europe. My name is Carmen Monge, and I'm a researcher and patient advocate for Youth Cancer Europe. I'm also a person with a lived cancer experience and also a migrant. Today, we will explore how migration can affect not only the diagnosis, the risks, and the prevention, but also the treatments and the follow-ups. So this session will be recorded, and feel free to put the questions that you have, and we will have time at the end of the webinar to answer them. So the first thing that we want to do is to ground our session on the lived cancer experiences that we have. We want to put this video so you can see April, that she's going to be in the panel as well as me, explaining a little bit about the challenges of being a migrant and being a person with a lived cancer experience. So listen closely and stay tuned until the end. See you in 5 minutes.
I have lived in many countries, and the difference how I feel about the country is inclusion. So it's like when you are invited to a home of someone and you get there and you don't know what to do. For example, in the Netherlands, you remove your shoes, right? Or you go directly to wash your hands. But it's something that you know beforehand because they tell you about it. So you get to a country and you don't know any of the customs because you are new. And people in the country expect that you know. And that happens in the healthcare system. And I know that it's very difficult as a migrant, as a refugee, as someone that is migrating to another country, because in a way, you feel that you are like an imposter for being living there, that you don't deserve to be there. And if you are being treated badly, you are very afraid to say something because you feel that you are ungrateful.
The hospital that treated me, they were really nice, but patients who went there, like like elderly people, they still judge you, like, oh, taxpayers' money, or like, you know, she should not be here. They will think because I'm married to like a Dutch guy, white guy, and I'm brown, I'm Asian, and I'm always inferior. Like it's like my husband needs to decide for everything. For what I eat, what I drink, how my treatment will go, what medicine should I take, what medicine should I not, what operation should I have. She married a white guy because she needs his citizenship, money, or better healthcare for what? Free cancer treatment. I look totally different from them. They can judge me from head to toe. They will say, she doesn't belong.
I'm from Costa Rica. I have my cancer treatment there. I got a portacat, that is a catheter. You have to clean it every 2 months because if not, you can get a stroke. Since it is so expensive in Costa Rica to put one of those, they don't remove it until you have 5 years of remission. So I had to travel to Australia having that. So when I got there, it was quite difficult because I didn't have the treatment there, and they didn't understand why I still have it, because in high-income countries, they just remove it when you finish the treatment. I spent like 4 months without cleaning it. Every day I was thinking like, oh my God, I'm going to have a stroke because it's not clean. I came here to Europe to study my master's, and thanks to that experience, I told them to remove the portacat, and they made me sign like, if I get cancer again, I cannot put it like in the 5 years because I remove it by choice. If I was feeling bad, it was quite difficult to go in every hospital and explain everything again in different languages. There were so many countries that I was not expected to be there as a patient in a way.
I struggled less with my diagnosis, actually, with having the cancer. but more of like, struggling to fit in the community that's not really very welcoming. Yeah, it's not good for your physical health. It's not good for your mental health. It's not really good. I think I'm still more lucky because I have a husband who is Dutch, who can stand for me or who can fight for me or for my rights. But I cannot imagine for people who just move, like couples or husbands and wives who just move, and it's just like the two of them against the Netherlands.
Now I have been living in the Netherlands for 7 years. Honestly, the healthcare system is so different to the other ones. The whole cancer network is really good. I have seen it is really good, but I realized that nobody told me since the beginning. Even like all the doctors knew that I had cancer. Nobody told me that, okay, there is these AYAs organizations that help cancer survivors, especially with mental health or fertility. Is because it is only for people that speak Dutch. I realized that maybe it's not me. I wasn't treated badly because I'm a foreigner. It's just that the system is like this and different.
Before, I was just like thinking, oh, I would just keep it to myself. Why do I voice it out? I'm done with it. I'm a survivor now. I can live a normal life, but I just want to break, I guess, the stigma.
For me, it feel including the societies that you go, and actually people treat you well, and they say like, good that you're here. Not good that you're in the hospital, but like we are here for you. And that is like in a personal level, it's very important that people know how to make others feel included.
Okay, so welcome back. This was a little bit about our story, about April and mine. But on the panel, April is going to share a little bit more about her story. So, oh, another one. So it's great to have you here. Let's appreciate the diversity of our audience. As you can see, we had 80 registrations, and we had people that they are people with a live cancer experience, healthcare provider, researchers, policymakers. Also, we have academics and just people that they were just curious about this topic, right? And we have more people with a live cancer experience than not. So great for us. Yay. So there is people from everywhere, especially from Europe, but we have people from the US, Canada, Brazil as well. And I'm very happy that you are here and that this topic is important for you as well, because it's important for everyone. For many of you that you don't know who we are, we are Youth Cancer Europe. We are a pan-European patient advocacy network that represent people below 40 that had a live cancer experience. We are in more than 40 European countries, and we are shaping the European policy, like in topics of financial discrimination with the right to be forgotten, fertility preservation, mental health, and many things more. We are also influencing the legislation and the healthcare system, not only at European level, but also local and national level. Also, equity, diversity, and inclusion is in the core of everything that we do. And that is why we are here, because we want to talk about an underrepresented and underserved population that are migrants. And migrants are very important. Actually, every year there are more migrants, especially in continents such as Asia and Europe. Something important is that migrants are a young population. More than 50% of them are below 40 years old. And in Europe, 1/3 of the migrants are between the ages 20 and 39. That basically is the range of ages that Youth Cancer Europe represents. And what about like the people that migrates? Well, they migrate for many reasons. This could be work, study, conflicts, family, or to find a place that is safer for them. They come from different culture, they speak different languages, they have different needs, especially in the healthcare system. But the healthcare system is not built for everyone. It can be hard to get the care that you need and the support, especially when you are far away from home and you don't understand the system. So first, I want to talk a little bit about terminology and inclusive language. So we are on the same page in the whole webinar. So first, what is a migrant, basically? Well, a migrant is anyone that they move from their country that they were born or their usual residence. This could be a person that they move by choice or by necessity. It doesn't matter their legal status or the reason why they are moving. They are just moving. Then we have the displaced person that they are basically forced to flee their home. This could be because natural disasters, this could be because of conflict or human rights violations. So it is more broad, right? And then we have refugees, that they are displaced people. They were forced to flee their country, but they have a refugee status under international law. Right now, there are around 35 million refugees in the world. Then we have the asylum seeker, that these are basically displaced people that they are looking for the international protection of a refugee status. So we have 5 million in 2022. And lastly, there is a term that I want to tackle, and it's about inclusive language. Because when you are a migrant, you have heard this one, I'm sure, that is the term expat or expatriate. Officially, is the same that a migrant is someone that is living outside their home country, but it is a term that is sociopolitical use to determine a people that comes from high income countries or that they have a certain type of job, a privileged status, I will say. So I will encourage you to not use this one because it makes the difference between a bad migrant and a good migrant. And it can reinforce stereotypes and can reinforce bias. So that is something that we talk about a lot in Youth Cancer Europe, to use the right language. So when you talk about a migrant, just say a migrant, don't say an undocumented migrant or something else, because this can reinforce stereotypes and also disparities as well. And that is other thing that happened to migrants, that we have health disparities in the healthcare system. Why? One of the reasons, obviously, is the language and the cultural barriers. Also, when you're a migrant, you don't know how the healthcare system works. So it's difficult to approach to the hospital and ask. Also, we are excluded from the national health system and the national health plan. We also have poor living conditions. There is a lot of discrimination regarding buying or renting a house, or even for the health insurance. It could be very expensive depending on the country, if it's social security system or if it's private security system. Also in the humanitarian settings, like refugee camps, the access to medicines and the hospital infrastructure could be very bad. So that is something to take in mind as well. Mental health, it could be worse than before. So there is more risk of having depression, anxiety, PTSD, feeling lonely. And I have to clarify that there are some groups that is even more difficult for them, like people with disabilities, women, neurodivergent people, and children. One thing that we did in Youth Cancer Europe was that we want to know the main disparities that young cancer people face in the healthcare system. So we did 3 things. Well, we have done many things, but the first 3 things that I'm going to mention is a literature review, a systematic literature review. And we did 2 surveys, one for healthcare providers and another one for people with a lived cancer experience. We want to know what was their perception about EDI, basically. And with all this information, we came out with the recommendations for an equitable, diverse, and inclusive cancer care in Europe that you can see it. You can check it out, and my colleagues are going to put the links as well. And in this, we realized that there is a lot of disparity regarding migration and ethnicity as well. 40% of the people with a lived cancer experience in the survey report having been displaced from their home countries at any point of their life, not only the treatment. Also, 12% of respondents receive at least some part of their treatment outside their home country. And 10% of them, sadly, reported experiencing or witnessing discrimination related to race, ethnicity, nationality, culture, and religion in the healthcare system. So check it out if you want to know more about the recommendations, but a little summary that I can give you is about the main actions that we found to tackle the disparities regarding ethnicity, migration, and refugee status. The first one is that thanks to the literature review, we realized that we don't have enough research, not in Europe, not in the world. And what happened? If we don't have data, we cannot put a number, so we cannot fix it, right? So we need to put more data about ethnicity, about migration on all the research that we do. In addition, we need representation in the decision-making of different backgrounds, and we have to improve the health messages to diverse population, not only about health literacy, but also in the hospitals, like all the consent forms and all things has to be in different languages. For that, we need more resources. We need interpreters and translations, and definitely we need training for healthcare providers, researchers, and patient organizations about cultural humility. So now let's go for today's speakers. So we have 7 speakers. There are a lot of speakers today. We have 3 main speakers that they are going to share a little bit about their research. There are Adam Sullivan, Ninki Alberts, and Flor Bratic. And also we have people with a lived cancer experience that they're going to share about their process before cancer, during cancer, and after cancer, and being a migrant. So we have Rasika Bombaka, we have Svilana Halusa, and Natalia Rat, and April Dorenbos. So I will give you a little bit about how it's going to be the outline of today's webinar. First, we're going to start broad with Adam, that he's going to explain the difference between a stage diagnosis between migrants and non-migrants on the OECD countries. That is more global, but they are still a small group. Then we are going to have the more narrow it down to Europe. So Ninke is going to explain about the inequalities in cancer risk across migrant populations in Europe. Lastly, on the speaker part, we are going to have Fleur that is going to explain about the PEACH project, that is cancer prevention on refugees and displaced population in 3 main countries in Europe. And lastly, we're going to have our panel with the young migrants across diagnosis, treatment, and follow-ups. So I'm very happy to introduce you to Adam. Adam is a doctor and he's currently doing a secondment in the NHS in London. And also his research has been focused on tackling inequalities in healthcare access and outcomes. He's studying exploring cancer diagnosis inequalities for migrants and the impact of self-referral pathways on health inequalities. So Adam, the floor is yours.
Thank you very much, Carmen. And thank you to Youth Cancer Europe for inviting me to speak. It's a real pleasure to be able to speak with you and to start with that very powerful video. So yes, I'm a doctor based in London. I'm a family doctor, we call a GP, but also an academic and a policymaker. And so I'm going to speak to you about my research that compared stage of diagnosis for migrants and non-migrants. So if we go to the next slide, please. So I wanted to start with a story just to make it come alive a bit, and some of this may resonate with some of your experiences and your expertise. So let's imagine Fatima. Fatima's 25 years old. She came to the UK from Syria as a refugee in 2019. Like many young adults trying to build a future, she juggles work, studying, and helping to look after her younger siblings. The pressure to adjusting to a new life in a new country leaves little space for her to focus on her own health. One day, Fatima discovers a lump in her breast. She brushes it off, hopes it's nothing. She's too busy to worry about things right now. There are things to get on with, rent to pay. But time passes and the lump grows. Fatima tries to go and register with the local GP, the family doctor, but is turned away because she doesn't have the right identification documents. Confused and intimidated by the system, she was also afraid that what this might cost her and there might be some hidden cost of it. She feels stuck. So time passes and the lump grows, and it becomes so painful and prominent that she takes herself to the local emergency department. The language barrier makes it hard for her to explain her symptoms clearly. The staff are busy. They try using a telephone interpreter, but it doesn't really work, and she feels unheard and unseen. They tell her to go to see a GP. They don't even know she doesn't have one. So more time passes, and the lump grows. And now the skin on her breast starts to change, and it becomes even more painful. Fatima is frightened and unsure where to turn. Eventually, with the support of a youth support worker in a local community centre, she successfully registers with the GP. She gets an appointment, she sees the doctor, and her concerns are taken seriously. She is referred urgently for suspected cancer to the local specialists. If we go to the next slide. Finally, she is diagnosed with stage 4 breast cancer. Now, her survival at 5 years is 26.2%. If there had been no delays, if she'd been diagnosed at stage 1 right at the beginning, her 5-year survival would have been 98%. So her chance of dying has gone from less than 2% to now 3 in 4. Delays in cancer detection result in later diagnosis and worse outcomes. So it really does matter. Next slide, please. So this takes me to the research. This was where we compared stage of diagnosis between migrants and non-migrants across the OECD. Next slide, please. So I'm sure many of you know this already, but just to make sure we're all on the same page, what do I mean when I say cancer stage of diagnosis? Well, this I've taken from Cancer Research UK is a really good summary. And so effectively staging describes the size of a cancer, how far it has grown, and how far it has spread. Now, there are different ways that you can define this, but broadly in this study, we looked at early and late. And broadly, the earlier you get a cancer, the better it is. Next slide, please. So our hypothesis, our theory, is that migrants face difficulties accessing getting the medical care that they need. And this makes it less likely that their cancer will be found at an early stage. So what did we do? Next slide, please. So we looked at the evidence out there, we looked at published literature, and we looked at people who were diagnosed with cancer and that had information for how advanced that cancer was. So was it early or was it late? And we compared people diagnosed with cancer between those who are migrants and those who are not migrants. Generally, we focused on those who had symptoms, so those who'd gone to the hospital because they had problems, rather than those who were picked up through screening programs, whether that's breast cancer screening or cervical screening. And to help with comparisons, or we're comparing more like with like, we focused on what are called the OECD countries. And we looked between the years 2000 and 2023. As Carmen has already touched on, that was the definition of migrant that we were working with. And our search identified 11,500 articles, 85 of which we fully screened, and 41 were included in our study. We then took all the results from these studies, we put them all together, we ran the analysis, and we compared to see if migrants were more or less likely to be diagnosed with an early stage of cancer. Next slide, please. Now you can see here the studies were from all over the world. So they covered lots of different cancer types. They covered multiple different study locations, although the predominance was within America and Europe. And it looked at different classification systems. Next slide, please. So what did we find? So you can see on the right there a little diagram that shows all the studies lined up next to each other. And ultimately, what our headline finding was among those diagnosed with cancer, migrants were significantly less likely to be diagnosed with early stage compared to non-migrants. The odds ratio is 0.84. So what does that mean? That means migrants, on average, overall, were 16% less likely to have an early stage of cancer diagnosis. And remember, the earlier it is, the better it is. Next slide, please. Now, we analysed this by different cancer types, and there was variation by different cancer types, but the trend was broadly the same. But breast and prostate cancer showed the strongest association. Next slide, please. We also looked at how it varied by where migrants came from and where the studies were located. And again, we found variation across it, as you'd expect. People have different experiences, and that informs the likelihood of they're getting a diagnosis early. But overall, the trend remained the same. Next slide, please. So, in summary, this is the first study that combined the different research papers to look at how early cancer is diagnosed with migrants compared to non-migrants. And as I said, our headline finding is overall, migrants were less likely to be diagnosed with cancer at an early stage. This means that the cancer is more likely to be advanced when we found it. Although there was variation by cancer type, by where people come from, and where the study was done, the trend remains true across the board. Next slide, please. So this supports our theory. We didn't directly test that theory, but it suggests evidence to support it that the barriers experienced by migrants can result in worse cancer diagnosis. Now, it's really important that this is just the beginning of the process, and we need to start to unpack how it's different for different types of cancer, different types of migrant, and different countries. And there's lots of things to uncover. And to understand that, we're at the moment of conducting some further research, doing interview work and more data work to truly unpack some of these differences. Next slide, please. These are two further studies that you can read if you're interested. So the one on the left is an editorial which was written about our paper, and the one on the right is a more accessible, less academic paper that makes it a bit easier to read, that explores a bit of the information behind the paper. So the links are in the chat. Next slide, please. So finally, thinking back to Fatima, what must we do? Well, as advocates, we've got to continue to highlight this underrepresented problem for this underrepresented group. As clinicians, we must think about inclusive practice, making safe surgeries, using interpreters, and using cultural competent practices. As researchers, we need to explore and mitigate the inequalities in cancer diagnosis for migrant communities. And as policymakers, as cancer detection and early cancer detection becomes an increasing policy priority, we must make sure that any new policies we develop don't leave migrants behind. Next slide, please. Thank you very much for listening. I really appreciate all your concentration. And I think we're going straight into the next presentation. So I guess any questions can go into the chat. Thank you.
Thank you, Adam. Okay, so now we will shift from diagnosis to cancer risk with a broader look at inequalities across Europe. So Dr. Nike is our next speaker. She is an epidemiologist and served as an assistant professor in the Department of Epidemiology and Data Science at Amsterdam UMC. She is also a visiting scientist at the International Agency for Research on Cancer and works at the Public Health Service of Amsterdam. She has a global, national, and local perspective on the prevention of cancer among individuals with a migration background. She is the principal investigator of the Project Cancer Radar that she's going to explain right now. Hi, Dr. Nike.
Thank you, Carmen. Thanks for this nice introduction. You can hear me well? Okay. So, today's presentation, I want to tell you more about inequalities in cancer risk among migrants. But first, I want to start with can you go to the next slide, Carmen? Yeah. Want to start with this intriguing sculpture made by Bruno Catalano, which represents a migrant leaving part of himself behind while taking its luggage with him. This luggage contains a story, but it also contains the epidemiological context in which this person grew up in and will continue accumulating along in its journey. This epidemiological context can also result in inequalities when compared to the new country where he or she moves to. Next slide, please. Well, to understand these inequalities better, the WHO launched their first ever global research agenda on health, migration, and displacement. And what they mention is that there is a huge lack of evidence and data to generate policies. The Europe's Beating Cancer Plan also realized this, and therefore they launched this European Cancer Inequality Registry, in which they stratify data by country, sex, education, income, urbanization, and age. But there's one very important factor missing here, which is migration background. We know that 12% of the European population has a migration background, and we will expect that this number is going to grow in the next few years or decades. But there are two simple reasons why this data is not there. One, we are not collecting this data in a systematic way, and harmonizing the data can be quite challenging. So you can go to the next slide. So with Cancer Radar, we want to change this. With Cancer Radar, we want to map the cancer risk among migrants across Europe. Next. So in the preparation phase, together with registries across Europe, we developed the protocol on how to safely and anonymously collect this data. And in Objective 1, we will start assessing where in Europe this data is available, collect this data, and estimate how much more or less risk migrants have compared to the new country they live in. Next slide. Then with this data in hand, we want to estimate what we can expect in the future and what fraction we actually can prevent if we offer them the right health. As Adam just mentioned, offer them screening and engage them into screening. This can prevent a lot of cancers in the future. Next slide. But estimating which fraction you can prevent, you also need to understand what resources are needed to prevent that. So that's the objective that we will do in Objective 3. Next slide. So in Cancer Radar, we will map the risk for 6 different types of cancers. Next. And we will do that for infection-related cancers, namely the stomach, which is caused or can be caused by Helicobacter pylori. Liver cancer of hepatitis B and C are very important risk factors for. And cervical cancer, which is caused by human papillomavirus. Next. And we will be also focusing on screening detectable cancers, which also includes the cervix, but also the colon, the breast, and the lung. Next. So in the next 2 slides, I want to show you the feasibility, whether it's possible to collect this data, and 2, some preliminary data that we have been accumulated with pilot registries. Next. So to understand where this data is available, we send out a survey to 104 cancer registries in Europe. A registry collects this data in a systematic way, collects cancer data in a systematic way by region or by country. And actually, we received quite a good response from those. 77% sent out a response, and of those that responded, 69% indicated to have this data available or willing to retrieve this data by merging different databases. But having this data in-house does not mean that they are actually able to share this data with us. There were reasons mentioned to share this data, which some registries indicated to have sufficient time, finding this an important project to contribute to, also that it's together within a network and that it is aligned with already ongoing initiatives. But also important barriers were mentioned, namely the limited staff capacity. Oh, we're not there yet, Carmen. Capacity collect and clean the data. They have no budget actually to allocate personnel to collect this data, and the data sharing and retrieval was perceived as complex. But with Cancer Radar, we hope to overcome these barriers and to actually achieve this goal. Next, please. So we tested the data processing with 4 registries, and we can make 3 important conclusions. The data are available at the registries, so they can be shared. The analysis is possible, and we are able to analyze them at the registries to make sure that the data is shared in an anonymous way with us. And the coordinated international analyses enable more meaningful conclusions than those possible from individual countries or registries. So by analyzing it in the same way, we can interpret it in the same way. And then the conclusions that we can make from the data that we have received up to now is that individuals with a migration background compared to the host population often have a decreased risk of colon and breast cancer, but an increased risk of cervical, stomach, and liver cancer. And this size of this disparity can depend on the gender, the cancer type, and the risk on cancer in a birth country. But what we observe is that the risk of the migrant converge towards the risk in a host population. Last slide. So Cancer Radar has many long-term goals, but the most important one is to improve the health of migrants. As Carmen already said, we need to close this knowledge gap and understand the size of these disparities to be able to inform public health decision makers. And I want to end with one important point. We must be aware that this data can be used can be interpreted differently according to different set of values, and our goal is to communicate the results of this work to promote equity-focused policymaking. What I want to say is that we need to be very careful on how we communicate this data because we want to improve the health of migrants with that. Last slide. So this work would not have been possible with Cancer Radar Working Group, as you can see here, and I want to thank them for all their effort in this.
Thank you, Ninke. We're going to leave Ninke's email on the chat so you can communicate with her. Now our next speaker is Flor Radic. She is a human scientist and medical anthropologist specializing in public health research, project coordination, and science communication. For over 20 years, she has contributed to European projects on health promotion, disease prevention, addiction research, and capacity building. Now she's going to tell us a little bit about the project pitch. So that is going to talk about refugees and displaced communities in Spain, Poland, and Czech Republic. Hi, Fleur.
Hi, great. Thank you so much for having me. I'm really honored to be included in this webinar, and it's also a pleasure to go after the impactful video we've seen and these 2 excellent presentations. So as Carmen said, we're going from the more global to the more focused in geographical terms, but in some ways, in terms of the content of the project, we're also going a bit more unfocused because Peached is a primary prevention project and it's an implementation project. So I'm not going to go through this slide because I will put the website of the project in the chat, and you can go straight to the next one, please, Carmen. So Peached is an EU-funded project based in Spain, Czech Republic, Poland, and with also partners in Portugal, and dealing with or working with the Ukrainian refugee populations in Poland and Czech Republic. The primary goal of the project is prevention of cancer and other NCDs. And Peached is developing or has developed a tailored intervention program, which is trying to address multiple lifestyle risk factors. So these would be risk factors in terms of behaviors that people can change and avoid in order to reduce their cancer risk. And we're piloting this program in 3 countries, in Czech Republic, with Ukrainian doctors who see relocated or migrants who live now in Czech Republic rather than Ukraine. In Poland, in refugee reception centers, with the staff who work in these centers, and in Catalonia, the autonomous region of Spain, we are looking at we're piloting this program in primary health centers. Next slide, please. So we are not quite halfway through the project. You can see now in May 2025, we're just starting the pilots. And this starts with training the health service or community service professionals to deliver the program. Next slide, please. So what is the PeachD intervention? Basically, it's a program which uses a technique called brief motivational intervention. This is, to put it in much more usual terms, this is a respectful conversation between a service provider and a service user, which explores their values and their priorities to try and encourage healthy behavior. So the whole idea of it being a motivational intervention is that it's not intending to impose something in the sense of an intervention we might have seen in a film or in the case of addictions and so on, even though we do deal with addictive behavior. So it's not imposing or forcing. It's supposed to be an exchange of information to help someone make healthier choices. Next slide, please. These are the behavioral risk factors that we're addressing. So these are all well known and have been classified by IARC as cancer risk factors. And the important thing about Peached, which is unique in a way, is that instead of addressing one of these factors, we're trying to address all of them to create a kind of win-win situation, because it's well known that not only does the risk increase with multiple behavioral risk factors. So if you smoke and you also drink alcohol and you also don't move very much, it multiplies the risk of cancer. But also we know that if we address one, it also makes it easier to address the others. So we're trying to kind of go for this synergistic behavioral change intervention. Next slide, please. So why are we looking at refugee or migrant populations? I use the word refugee. I really was glad, Carmen, that you mentioned the inclusive language, but we specifically use the word refugee as well as migrant population because the two different groups that we're looking at in Czech Republic and Poland are in very different situations. And we were told by our Polish partners and by the Ukrainian people we met there that it's important that they're refugees because it does give them some extra access to healthcare that they might not have if they didn't have refugee status. So more or less, we know from the literature that there are barriers to healthy lifestyles for those who are migrating to a new country. There's also, as well as the pre-migration risks, there's also a risk of health deteriorating post-migration. And as Carmen also mentioned, there's this intersectional factors, like the fact that many of the people coming out of Ukraine and settling in or trying to settle in Czechia and Poland are women and children. And this altogether means that we need a sort of much more linked up response, not only through the healthcare, but also through the social care systems and the integration systems. So the other thing that was really impactful for us when we went to Poland and started talking to the people who would be delivering this program was that they were saying that the main, one of the main things they were encountering was a high level of which we could expect, was a high level of trauma, of course, from leaving their country in situation of war. And we really felt like this impotence to try and do anything about this. Luckily, our coordinator, who has worked in crisis situations and is a psychologist, was also pointed out that although we can't control these huge geopolitical situations, what we can do with something as simple as trying to encourage a healthy behavior change is put a bit of control back into people's hands. And this can contribute to coping or a resilience in the face of such high stress situations. Next slide, please. So we come from the alcohol field with this intervention. So brief interventions is a kind of tool for changing behavior with regard to drinking. And we are now trying to adapt it to a different set of factors, but also to a very different context than the health service where it's being used. So we had to consider all kinds of different aspects that needed adapting to make it context specific and appropriate for these areas. So I'm not going to go through all these because there's a lot of text, but more or less, as well as changing country, we also had to look at the different people who would be talking. So rather than healthcare providers, we're now talking about people who don't have a training in health necessarily, and work in a different system. So they work in these reception centers, which have different rules, different priorities, and different end users. So rather than people coming with a health, thinking they're going to talk about health, they might be coming with a completely different set of preoccupations. Next slide, please. So I want to just pay note to Nicole Lavrova, who is a young researcher who's been doing an internship with us, because I'm going to use some of her slides because they were so excellent. So I can put her link in the chat and people can contact her if they are interested in what she's still currently working on. So her thesis is on the health promotion interventions for refugees in Europe. Specifically, she was looking at any health promotion, not specifically cancer prevention. But as the risk factors are often shared, then this is still relevant, very relevant to our work in PhD. Next slide, please. So she was using what's Kreuter's strategies for cultural health promotion communication, and these touch on a bit what we saw in the video, that as well as so the most basic perhaps is the linguistic one, which is the second line here, which is absolutely essential for understanding, but also we find that we need a two-way adaptation. So as well as people who are new to a country trying to learn the language, we also need to bring all the material closer linguistically to their capacities. As well as this, you quite often find more sort of superficial adaptations, such as traditional clothing or culturally familiar images, and also using data or facts or stories which are more relevant to the migrant group. And then we get to some what you might call more in-depth adaptations, which could include embedding cultural beliefs and traditions. But essentially, this last row on the table is in fact not really a kind of continuum, but could be used throughout. So this is about involving the community members and the group members of the migrant group in as many stages of the development of a program or a health promoting or a cancer prevention program as possible. Next slide, please. So Nicole did a literature review, and she assessed whether the programs which she found literature on had actually taken or reported these kind of adaptations. And she found that 100% of the 13 programs that she found were had done a linguistic adaptation. Fewer had done the sociocultural adaptation. But nearly half had involved their constituents in the work. And then once you got down to sort of peripheral adaptations or including data that was relevant, it got very low indeed, or perhaps it wasn't reported. So one of the points that we want to make is that in order to be able to replicate and build on these successful experiences, we really need to know about kind of minute details about what is being adapted, how are health promoting programs reaching the migrant populations? Because as Adam and Nienke have mentioned, there's there's an inequity here. So there's inequity in terms of the diagnosis of cancer, accessing screening and getting diagnosis early enough. But there's also an inequality in the access to prevention initiatives. And these, I think, really need to be addressed by sort of spreading knowledge and a knowledge exchange in terms of how we can make these programs much more equitable and much more accessible. Next slide, please. So in general, the challenges seem to be that there's sort of limited resources for culturally adapting interventions. The time and funding is kind of focused in different areas. There's also a great diversity, of course, within these migrant populations and refugee populations. And in a way, we're balancing something that's scalable against something that's specific. So whether we can increase outreach or target more exactly. And finally, we have another balancing act to do between whether we stay faithful to something that works in a host population and how deep we go in adaptation and adapting a program to a new population before we start losing effectiveness or evidence-based effectiveness. Next slide, please. That's it. Thank you so much. Again, thanks so much for having me on this.
Thank you, Claire. That was very interesting. And thank you for saying about the terms of refugees, because that is true. That can change from country to country, right? So it's something very important to talk about. Also, the terms like ethnicity, race is different in every country. So we have to take that into account. So the next one is our panel with our young migrants with a lived cancer experience. As you can see on the diagram, they were diagnosed in different stages. Well, they migrate in different stages of their cancer process. And I'm going to introduce you to them, and then I'm going to ask a question to each of them. So the first one is April. She's from the Philippines, and she was diagnosed and treated in the Netherlands from endometrial cancer. Now she is an advocate, and she works on research and development, where she applies her passion for wellness to projects and promote healthier choices and lifestyles. April moved by choice because she wants to reunite with her family, different from Esvilana, that she moved by necessity. Esvilana has to move in 2020 from Belarus, and while she was applying for the refugee status in Lithuania, she was diagnosed with a late stage Hodgkin lymphoma. Now she holds a refugee status and works in logistics and engaging in volunteering activities. Also, in her spare time, she educates people about cancer through her TikTok account, so follow her up. We're going to put all the links about the social media of them and everything so you can follow them. Then we have Natalia Rad, that she moved from Ukraine to Poland during the war while she was on treatment. So her story is a little bit different. Natalia is a patient advocate for Youth Cancer Europe, and she also holds a PhD in linguistics. And she has been a teacher for 15 years in the English language. Now, the last one is Rasika Bambaka. She was diagnosed and treated in India, and then she's doing the follow-up in the UK. Rasika is a public health researcher and lung cancer advocate. She has a background in physiotherapy and a master's degree in international health from the University of Oxford. And she currently works as a research associate. Rasika also volunteers for the Lung Connect India Foundation, where she supports lung cancer patients. So, hi everyone.
Hello.
Hello. So the first question, how can I see you? Let's see.
I think you can stop sharing and you're gonna see all of them.
Okay, perfect. So hi everyone. So the first question is for April. So we already know a little bit about April's story, but I want to know more about how was to have cancer far away from your family, especially with the stigma around cancer in your home country. How that affect you emotionally?
Yeah, so good afternoon, everyone. So to answer the question, going through cancer while migrating and far from family can feel isolating and very overwhelming. Battling illness with your not not with your usual support system in a very unfamiliar environment, often facing language and cultural barriers, it's very difficult. Yeah. And from where I came from in the Philippines, the stigma it often comes from fear, like lack of awareness and cultural beliefs. People, most Filipinos, they will think like it is a hopeless illness, like it's a punishment, like it will lead to shame or kind of like silence. So most cancer patients, they are kind of like scared to like voice out. And also, I think when it comes to healthcare, it's very limited. Limited access to healthcare and the cost of treatment is very high and makes it even harder. So people try to avoid to talk about it or delay getting help or delay some kind of getting treatment. And how do you say, like moving here in the Netherlands is also a bit challenging because I came from a country where it's totally different. It's from the other side of the world. So at first, I felt really sad and depressed, and it's very difficult to cope with it because at first I didn't know that there are certain cancer group supports or like peer supports like AYA and Youth Cancer Europe to you can share and they can help you out with these things, to process emotions and like accept help from them. Yeah.
Thank you for sharing, April.
Thank you.
And yes, can be very difficult, right? Especially to communicate where are you having all your feelings to people that is very far away from you because you don't want to worry them as well.
Yes, actually, until now, my parents didn't know that I got sick. I mean, most of my families, they know, but I cannot really tell my parents because, you know, moving to the Netherlands it's a different story. Plus, moving to the Netherlands with cancer is totally different. Like they will be so worried about me and my situation.
Thank you, April. Now we move to Svetlana. You left Belarus in 2020. During your wait for asylum in Lithuania, you were diagnosed with a late stage Hodgkin. And based on your experience, what do you think need to change so that refugees and people in and asylum seekers with cancer can receive a quick diagnosis or a better treatment, especially in refugee camps or people that are still in a legal limbo?
Hello to everyone. Since I live in Lithuania, I can speak only about problems of refugees in this country because I don't know what situation have migrants in other countries. But I will try to tell on based on example from Lithuania. So the first thing and maybe the most important is that medical staff in clinics, in hospitals doesn't know how to work with refugees at all. He doesn't know that according to the laws, Lithuanian laws, refugees have a right to have free of charge treatment. They don't know it. They don't know that refugees don't have ID cards and any ID numbers like people, for example, who have Lithuanian residence of permit residence, and it's also a trouble because they require to show IDs, or people with refugees, people with who are waiting for refugee status can't do it, and they need to call to Caritas or any other organization who supports migrants and call and tell, please help us, we don't know what to do, the hospital requires us to pay money for the visit, and etc. So maybe my solution is to provide some trainings for medical staff about work with refugees, how refugees live, what documents they have, and that they have a right to have a treatment for free. And second, I would like to say is that in Lithuania, refugees usually live in the closed camps far from big cities like Vilnius or Kaunas, and they don't have access to medical help. For example, if the person after the chemotherapy, such person who lives in refugee camp after chemotherapy, he feels bad, for example, and he maybe has to wait for 2 hours for an ambulance, or maybe to travel same time to the hospital. And it's, to my mind, it's not very good idea, but my solution is to allow refugees to live with their friends. For example, in Vilnius, I had friends in Vilnius, and they invited me to live with them. So I hadn't such problems, but maybe other refugees have them, and they already have suffered very much. For example, if we speak about Belarusian refugees, many of them went through prisons, and they can't live in Lithuania like in prison, or where they are waiting for refugee status. And third thing is also very important. It's about financial help for refugees, because, for example, Lithuania, while waiting for an asylum status, doesn't provide any support, any financial support. I understand that this country is very small and they don't have opportunity to provide financial support for each refugee or asylum seeker. But to my mind, people with cancer, refugees with cancer, must have a right to receive some benefits from the government, just something for food and for pay for taxi, for example, because they need to drive to the clinic very often. And fourth problem, which is also important, is the support of people who had refugee or who had a cancer or other serious illness while waiting for refugee status. In Lithuania, they have to work mandatory for 1 year to receive maybe a disability benefit or benefit, sickness benefit, or some other benefit. And people who waiting for refugee status, they can't work, and they can't receive this mandatory 1 year of work in Lithuania to have a right to have these benefits. That's why I think maybe it's a kind of discrimination for refugees with cancer or other disabilities, and I think that it should be somehow solved, maybe to allow these people, to provide these people with the benefits they need.
Yes.
And of course, I would like, despite all of this situation, I would like to say thank you for my refugee status to Lithuania and for my treatment. And I would like to mention also that in Belarus, people in prisons, people with oncology, with cancer, don't receive any treatment at all. They are simply slowly dying in prisons. And if even the people who are not in prison, they also can't receive the treatment because many medicals are not allowed in Belarus, for example, and people have to gather money to gather donations to buy this medicine abroad and do injections in Belarus. That's all that I would like to say.
Thank you, Slana. Now we move to another case of refugee status, that is Natalie. You experienced cancer care as a refugee, and you have to navigate two challenges, not only the treatment, but also the war. How was that transition between going from Ukraine to Poland in a refugee status during your treatment?
Thank you, Carmen. Hi, everyone. Well, it was a rough path, I must say, definitely a rough one. So the main challenges that I faced, taking into account that I was lucky to apply via Youth Cancer Europe and also via my friends to seek for treatment, where the first one was the bureaucracy. You need to collect all the necessary documents in order to get your refugee status. And in Ukraine, you didn't have to do this because you're a citizen of that country, so you just go primary to the doctor. Here in Poland, you had to first to get your refugee status, which can take time, and time is very precious thing in our case. And the second thing, you have to wait for a doctor's appointment, GP, and then only getting with, via GP the directions to the oncologist. You also have to wait for the oncologist, and it can take from 2-3 weeks to 3 months. Nobody knows what will be the line for that, and that really differs from Ukraine, because in Ukraine you can also, like, the line is shorter and there are, I don't know, maybe more doctors, or the system is different, so that the patients can get quick at the scans, they can get quicker to the doctor, and they can start their treatment earlier. Another challenge that I faced as being a refugee and getting treatment in Ukraine to what I got used to, and differently to what I wasn't used to in Poland, was about the procedure, how was the treatment done. So in Ukraine, my chemotherapist was the main guy in my life who was telling me what will be my action plan. And here in Poland, I had a nurse as well as I had an oncologist, and this oncologist actually she was submitted by other oncologists if she wasn't at hospital, after her, I don't know, night shift. So it was hard for me to find out who is my oncologist for today and what's going on here. What else? The different treatment schemes and treatment protocols that are adjusted in Ukraine and not adjusted in, for example, whole Europe, because Ukraine is not a part of European Union, which was hard for me as well to understand what's going on and what will be the protocol here, and if we are flexible or no in that. Also to not being able to call the ambulance as well, because in Ukraine you can call the ambulance and the ambulance will be like in a blink of an eye. Here the ambulance will not come to you, at least if you're not dying. So if you're not dying, it means that if you are unconscious, they can come to you. But if you're conscious, you have to come to ER and just wait, as all the other patients have to wait. And yeah, that's it. And also, what was difficult from my perspective is the lack of the volunteers in the hospitals. For now, they do have, because I do my follow-ups there. But when I just got in Poland, it was hard. Nobody spoke English, like generally, only some of the people. Everybody spoke Polish, and I used a translator to speak Polish with them while I was learning my Polish. And nobody was there, to onboard you. And it's very important for any cancer patient to have the action plan and to get back the control, because when you're diagnosed with the cancer, the first thing you lose is the control of your life. So the main thing is to get the control by knowing what to do next. And when I finished my treatment, another thing was that in Ukraine, you can text your doctor directly. And here in Poland, you cannot do this. You have just to call to the registration office, or you can email your doctor and wait for it. So the timing is different, and it can, be difficult for a person who was adjusted to some other options. But now I'm adjusted to it and I'm totally okay with it, and I got used to. And I also want to thank Poland for actually saving my life. So yeah, I'm very thankful to that.
Thank you, Natalie. That is something that we talk a lot, right? Like about the different healthcare systems, especially, well, you were coming from Ukraine and then moved to Poland. That is still East Europe. But now we moved to Rasika. That actually she was diagnosed and treated in India, that is a low middle income country, and then moved to the UK, that is a high income country. So Rasika, how was that difference between the two healthcare systems?
Thank you for the question, Carmen. And I think, yes, as expected, the difference was stark because, yeah, coming from an LMIC where the system is totally different, as Natalie mentioned, you can just directly text your doctors and you can directly go and see your oncologist. Versus here in UK, you have to go through their system, go through a GP, send an email, get yourself registered. So the system is totally different. I must say that because I came for studies and I was associated with a university, so I had that support with me, and there was someone to guide me through the process and what should I do even before moving to the UK. And I see that that is a very big positive that helped me to have everything set up, and which should happen with all of us, irrespective of what status we're coming in. Because I had someone who would help me understand what the system is, how to go through it, and what to do next. So yeah, that whole anxiety and everything was taken down. But I think my biggest learning doing this shift is that the importance of knowing everything about my condition, like the smallest details. So I have, of course, in the broader sense, lung cancer, but something to do with a genetic mutation, and it goes into a lot of technicalities. And as someone, as a layman, I wouldn't be knowing that just as a matter of fact. But because I was doing this transition, and because the formats, the terminologies, and the medical documentation is so different in both the countries, that even if I sent all my documents to them, they weren't able to understand a few things, and they missed a lot of important points. And so I had to read all of those things and make myself informed enough so that I can tell them that, okay, this is what it is and this has been done. Which is sad, because as a patient, we're already dealing with so much, and we don't need to go through, reading articles which we don't even understand. But I had to do that, and that was the only way I could make them understand that, okay, this is what it is, and this is where it is written, and you can take it ahead from here. So yeah, that is how it was.
Thank you, Rasika. And you said, right, like it's a intersectionality. You are moving, you have cancer, and apart from that, you have to advocate for yourself because nobody else is going to do it. So it's a very good take-up message. So thank you, everyone, for sharing their experience. We already left all the social media of them, our contacts, so someone wants to follow them. And we're going back to the presentation. Right now, we don't have questions from the audience, so we're going to soon finish the webinar. Okay, so can you see this? Oh, good. So here are some resources that we got for you. We have videos, Natalie's stories on a YouTube video that you can check them out. And also other stories about Anna and Inessa from Ukraine, and some of their videos that we filmed during the focus group in Cluj. Also, we have a catalog of resources for Ukrainian cancer patients, but honestly could be used for any migrant because there are many good organizations in each country that you can approach to them and ask them topics about healthcare system, about the health insurance, or other topics that you are interested in. And now we go to Hannah.
Yes, hello everyone. My name is Hannah and I'm Administrative Officer in Youth Cancer Europe. And I would just like to share the announcements of our future event, which is Equity, Diversity and Inclusion in Cancer Care Stakeholder Forum, that will happen really soon on the 17th June in Brussels. And this event will bring together key stakeholders who are working to advance equity, diversity, and inclusion across cancer care in Europe. And we'll have representatives from EU institutions, research organizations, advocacy networks, EU-funded initiatives, and others to share their work and to exchange on how best to address disparities in cancer care across Europe. And for example, we'll have Annika Nowak, who is head of sector of the Cancer Mission Secretariat in DGRTD. We'll have Stefan Schreck join us, who is advisor for stakeholder relations in DG Sante. We'll have a member of European Parliament, Katrien Langenziepen, who is co-chair of Intergroup on Disability. And we'll have such organizations represented as, for example, ECO, EARC, EORTC, EONS, and many others, and also some great projects. For example, PIST, which Fleur was talking about today, and Cancer Radar, presented by Nienke today too, and many others. And the format of the event will involve short 5-minute presentations, contributions from each organization, from each project represented, which will be grouped by theme and then followed by open discussions within each cluster. And unfortunately, we're limited to 50 spaces, but if there is a good project, if there is national strategy we missed, we can see how to make space for them. And for those coming from outside Brussels, Youth Cancer Europe will cover travel and accommodation. You can scan the QR code and find further information in the invitation note. So if you're currently working within a project or within an institution that has a good EDI strategy, and you feel that it's worth sharing, then please don't hesitate to write to me directly to hannah@youthcancereurope.org. Please do it today or no later than tomorrow, and we would be happy to learn more and include you in the program. Thank you so much.
Thank you, Hannah. So now, some closing remarks. This was the last webinar from the EDI series. So we invite you to follow YCE to see the following EDI actions that we're going to make in the future. But if you want to check the last webinars, please watch them on our YouTube channel. Here are the links, but we're going to put the links as well there. So thank you so much for staying until the end. Thank you to the speakers and the panelists to make this webinar very useful and very informative for all of us. So thank you, everyone.